Welcome to the audio digest of the American Journal of Psychiatry. This is Michael Roy with highlights from our June issue. Featured in the journal this month, Cognition. Our treatment in psychiatry article is about cognitive complaints and depression following mild traumatic brain injury. Also featured, Cognition Research. We'll discuss two research articles on cognition and schizophrenia. One is a clinical trial that examined cognitive effects of antipsychotic drugs in first episode patients. The other analyzed the relationship between prenatal infection and executive dysfunction in adults with schizophrenia. Then we'll look at reward processing. We'll highlight how functional MRI was used to compare activity in the basal ganglia of depressed patients during the anticipatory and consummatory phases of reward processing, since they reflect different psychological states. After that, we'll turn our attention to inhibitory control, looking at children with ADHD and their parents, in a study that was designed to evaluate whether inhibitory control could be used as a trait marker of ADHD. Finally, targeting exacerbations. We'll discuss a clinical trial that compared extended-release paliperidone with quetiapine and placebo for schizophrenia patients requiring hospitalization. We begin this month with our Treatment in Psychiatry feature by Jonathan Silver and colleagues, who present a case of depression and cognitive complaints following mild traumatic brain injury. The patient was a 49-year-old man who worked as a contractor in Afghanistan. His vehicle had been hit by a roadside bomb 6 months earlier, and he developed depressed mood, sleep problems, fatigue, and cognitive complaints. He returned to the United States to recuperate and begin a new job assignment. However, his fatigue and cognitive problems interfered with job functioning, and they were complicated by irritability, dysphoria, lowered self-esteem, and pessimism. He took a medical leave of absence, and his wife insisted that he get psychiatric consultation. An elementary neurological examination produced normal results, and an MRI of his brain was read as normal. He performed slowly, but accurately, on the mini-mental state examination and a test of executive function, and he made only a few errors of omission on a test of vigilance. Now, the majority of individuals with mild traumatic brain injury, or TBI, recover fully, even without specific intervention. However, some develop chronic post-traumatic neuropsychiatric problems. When a patient is evaluated for conditions that may be the result of a TBI, it's important to determine whether the event preceding those difficulties in fact produced a TBI. Because the evaluation is retrospective, there's a significant potential for misreporting the event and its immediate manifestations. On the other hand, a lack of evidence for a TBI in the medical record doesn't constitute evidence of a lack of a TBI. Conventional neuroimaging of the brain is often interpreted as normal in persons with mild TBI. After TBI is diagnosed, functionally significant neuropsychiatric symptoms can be addressed. Education, counseling, and rehabilitative interventions may facilitate recovery and reduce the likelihood that the patient will develop long-term post-concussive symptoms. The evidence doesn't show that recovery is hastened by medication, but it may reduce the effects of symptoms on the patient's functioning and limit the likelihood that they'll become chronic. Expeditious treatment of depression after TBI is particularly important because it may alleviate other symptoms, reduce suicidal thoughts and behavior, and improve psychosocial functioning and quality of life. In prescribing medication, it's recommended to start low and go slow. Persons with TBI may be more susceptible to the side effects of many psychotropic medications. Selective serotonin reuptake inhibitors are generally regarded as the first-line agents for depression following TBI, and the available evidence favors sertraline and citalopram. In addition to decreasing depressive symptoms, SSRIs may improve comorbid somatic, behavioral, and cognitive problems. Psychological and social factors also contribute to post-traumatic depression. Education, reassurance, and frequent support are associated with better outcomes during the first year after the injury. Multidisciplinary treatment may be particularly useful for individuals with prior psychiatric problems. Cognitive behavioral therapy has been observed to decrease depression, anxiety, and anger after TBI. It can also improve problem-solving, self-esteem, and psychosocial functioning. In addition, psychotherapeutic intervention is frequently required for spouses, families, and caregivers of persons with TBI. After treating depression, it's appropriate to treat the patient's residual cognitive problems. Cognitive rehabilitation is most useful in compensating for difficulties with memory, attention, interpersonal communication, and executive function. It appears best suited to patients with mild to moderate cognitive impairments and relatively well-preserved functional independence. The neuroanatomy and neurochemistry of TBI yield two general approaches to the pharmacotherapy of post-traumatic cognitive impairments. These two approaches are catecholaminergic and cholinergic augmentation. Methylphenidate augments cerebral catecholaminergic function and is the first-line treatment for impaired processing speed. It may also improve arousal and, to a lesser extent, attention and memory. The cholinesterase inhibitors donepezil and rivastigmine may also be useful in treating post-traumatic cognitive impairments, particularly memory problems. Cholinesterase inhibitors have also been associated with improvements in attention and executive functioning. Individuals may have disparate long-term outcomes after seemingly similar injuries. This may be due to pre-injury factors, biomechanics of the injury, and genetic factors. The patient in our case vignette wasn't able to resume his previous level of activity, but his functioning and quality of life improved with cognitive rehabilitation and medication. The environmental modifications included noise reduction, compensatory strategies to help in organization and memory, and frequent breaks. His drug treatment consisted of citalopram for mood, methylphenidate for processing speed, and donepezil for memory. Now, we'll turn to our research articles on cognition in schizophrenia. Michael Davidson and colleagues conducted a randomized, open-label clinical trial on the cognitive effects of antipsychotic drugs in first-episode schizophrenia and schizophreniform disorder. The results of previous studies have been equivocal. The Clinical Antipsychotic Trials of Intervention Effectiveness, or CATIE, addressed many of the methodological problems in earlier studies, and it found no difference in cognitive improvement among profenazine and 3 second-generation antipsychotics. However, CATIE included chronically ill patients who are less likely to benefit from cognitive advantages of newer antipsychotics. Also, profenazine was the first-generation antipsychotic used, whereas haloperidol is the one most often prescribed. Furthermore, CATIE was blinded, and blinded trials don't yield generalizable results and limit the psychiatrist's ability to optimize dose for an individual patient. In contrast, Davidson and colleagues included only first-episode patients, used an open-label design, and compared haloperidol with several second-generation antipsychotics. Haloperidol was given in a low dose, 1 to 4 milligrams per day, because it has been argued that trials showing newer antipsychotics to be superior to haloperidol used haloperidol doses that were too high. The design was pragmatic and included patient groups that are often excluded in efficacy trials. For instance, patients with substance misuse and those who couldn't participate in blinded trials for safety reasons. The participants had a recent onset of psychosis, less than 2 years before the trial, and they'd been exposed to antipsychotic drugs for less than 2 weeks during the preceding year and less than 6 weeks over their lifetime. They were randomly assigned to open-label treatment with one of 5 drugs: haloperidol, amisulpride, olanzapine, quetiapine, or ziprasidone. Again, the daily dose for haloperidol was 1 to 4 milligrams per day. For amisulpride, it was 200 to 800 milligrams. For olanzapine, it was 5 to 20 milligrams. Quetiapine doses ranged from 200 to 750 milligrams, and ziprasidone doses were 40 to 160 milligrams. Within these ranges, the doses were at the discretion of the treating physician. Mood stabilizers, benzodiazepines, antidepressants, and anticholinergics were allowed, but additional antipsychotics were not. Approximately 30% of the patients were already taking anticholinergic drugs or began taking them during the study. 5 cognitive tests were administered: the Ray Auditory Verbal Learning Test, Parts A and B of the Trail-Making Test, the Purdue Pegboard, and the Digit Symbol Coding Test of the Wechsler Adult Intelligence Scale. Nearly 300 patients had valid results at baseline and month 6 for at least 3 of the 5 tests. The scores were standardized, and a composite score was created for the entire set. Change in the composite score from baseline to 6 months showed improvement for each of the 5 antipsychotic drugs, with no overall difference among them. A lower baseline score was a predictor of greater cognitive improvement. Also, the change in score for the patients who began taking anticholinergic medications during the trial was similar to that for the other patients. The change in the composite cognitive score was negatively correlated with the change in scores for psychotic symptoms. This indicates that cognitive improvement was associated with symptom amelioration, but the magnitude of these correlations was very small. In an editorial, Terry Goldberg and Jesus Gomar discussed the trend of targeting cognition in schizophrenia research. They state that cognitive impairment is now considered a core symptom of the disorder, as it appears to be a major factor in determining a patient's ability to cope successfully with everyday activities, including vocation, social networks, and independent living. For this reason, efforts are being made to develop treatments for enhancing cognition, as well as to identify the underlying mechanisms of cognitive impairment. Goldberg and Gomar state that the results reported by Davidson and colleagues are consistent with those of CATIE, and that the investigators present convincing arguments that neither the open-label design nor study dropouts biased the results. The doses of haloperidol were low, but the test battery was heavily weighted toward tests of speed, which may have influenced the results. Slower responses were scored as cognitive deficiencies in executive function and working memory. Thus, Goldberg and Gomar call for standardized cognitive tests that better distinguish the different facets of cognitive dysfunction in schizophrenia. Goldberg and Gomar go on to cite 3 other specific factors to consider in the data presented by Davison and colleagues. The first is the effect of practice. Longer intervals, such as the 6 months in this study, may attenuate practice effects, but they don't eliminate them. For instance, verbal learning tests repeated at 2-year intervals demonstrate a practice effect with an effect size similar to that for drug treatment. Procedural or implicit learning may show effects of earlier exposure to the test that are especially long-lived. Second, the drugs used in this study have different binding profiles at receptors known to influence neurocognition, including the D1, D2, M1, and 5-HT2A receptors. The differences in binding profiles might make it seem improbable that all would engender similar degrees of cognitive improvement, yet they do. Third, if one assumes that a cognition-enhancing agent should also enhance cognition in at least some healthy comparison subjects, such as the elderly, there's little evidence to suggest that a class of drugs with high D2 receptor antagonist activity could improve cognition. Nevertheless, Goldberg and Gomar stress that it's important to appreciate that D2 antagonists have profound restorative effects on the neurocognitive underpinnings of psychiatric symptoms, including abnormal salience and delusions, and misattribution and hallucinations. Thus, understanding how the first and second generation D2 antagonists succeed, and how they fail, in reversing specific types of abnormal information processing may provide an important lead in understanding pathogenesis in schizophrenia. That brings us to our second study of cognition in schizophrenia. Alan Brown and colleagues used prospective data from a population-based birth cohort to examine the relationship between prenatal exposure to maternal infection and executive dysfunction in adult schizophrenia. The mothers of the cohort members were enrolled in a child health and development study between 1959 and 1966. It recruited nearly every pregnant woman receiving obstetric care from the Kaiser Permanente Medical Care Plan in Alameda County, California. During pregnancy, maternal blood serum was collected. For the current study, data were obtained for more than 12,000 offspring who were members of the same healthcare system between 1981 and 1997. The serum samples were assayed for toxoplasmosis and the influenza strains prevalent in Northern California between 1959 and 1966. Computer records were used to identify plan members with diagnoses of schizophrenia spectrum disorders and those who had received prescriptions for antipsychotics. These individuals were assessed with a diagnostic interview. 24 were diagnosed with schizophrenia spectrum disorders. Comparison subjects were drawn from plan members who didn't have any major psychiatric disorder. Executive dysfunction was assessed with 2 measures previously reported as being associated with obstetric complications: the Wisconsin card sorting test and the trail making test parts A and B. Tests included in secondary analyses were verbal fluency tests for both letters and categories, a figural fluency test, digit spans both forward and backward, letter number sequencing, and an auditory end-back test. The reading subtest of the Wide Range Achievement Test was used to estimate overall premorbid cognitive ability. 2 sets of comparisons were made: the schizophrenia patients versus the comparison subjects, and the 8 schizophrenia patients exposed to prenatal infection versus the 16 who weren't exposed. There were too few comparison subjects exposed to infection to examine them separately. As expected, the subjects with schizophrenia spectrum disorders performed worse than the comparison subjects on nearly all the measures of executive function. The schizophrenia patients who'd been exposed to infection in utero committed significantly more total errors than the unexposed patients on the Wisconsin card sorting test. They also took significantly more time to complete the Trails B test, but there was no difference in the time to complete the Trails A test, which measures psychomotor processing speed. The exposed and unexposed schizophrenia patients did not differ significantly in their performance on any of the other neuropsychological measures, except figural fluency. On this test, the exposed patients had significantly lower scores than the unexposed patients. Performance on digits backward and letter number sequencing was also worse in the exposed patients, but these differences didn't reach statistical significance. The Wisconsin card sorting test and the Trails B test both require set shifting, whereas the executive functions examined in the secondary analyses do not have a set shifting component. Thus, these and previous findings suggest that set shifting may be particularly vulnerable to the effects of prenatal and perinatal insults on the developing brain. Returning to the editorial by Terry Goldberg and Jesus Gomar, they place these findings in context. They state that prenatal infection with toxoplasmosis is associated with microcephaly, low IQ, and bilateral deafness in children. Given that the parasite causing the infection can't cross the placenta, it's assumed that elevated maternal immunoglobulin G antibody to toxoplasma is the agent that damages the developing fetal brain. How antibody titers selectively disrupt frontal-type executive functions is an unresolved question. Little is known about the consequences of maternal influenza infection in human fetal development. Prospective cohort studies are needed to identify the neurodevelopmental consequences of maternal exposure to influenza during pregnancy. One recent study found that among adults with schizophrenia, but not healthy adults, prenatal exposure to influenza was associated with a lower IQ at age 7. Goldberg and Gomar call for future research to help distinguish between cognitive consequences of prenatal infections and changes that are specifically related to schizophrenia. Now, we'll turn to brain functioning in depression. Diego Pizzagalli and colleagues report reduced caudate and nucleus accumbens response to rewards in unmedicated individuals with major depressive disorder. Anhedonia is a core symptom of major depression, and neuroimaging indicates that deficits in positive affect and responsiveness may reflect dysfunction in the basal ganglia. However, it's unclear whether the dysfunction is more closely related to deficits in the anticipatory or the consummatory phase of reward processing. Dissociating these phases is important for two reasons. First, they reflect different psychological states. Anticipation is characterized by goal-directed behavior, whereas consummation involves the experience of pleasure. Second, they make different contributions to motivated behavior. This study compared brain responses in depressed individuals and healthy subjects while they performed a task that provides cues indicating the potential for monetary gains, penalties, or no change, followed by the actual outcomes. The subjects were 30 patients with major depressive disorder and 31 matched comparison subjects. Data were collected before the patients began treatment. The task was presented during functional MRI scanning. Each trial began with a visual cue indicating the potential outcome: reward, loss, or no change. After a variable interval, a red square was briefly presented, to which the subject responded by pressing a button. After a second delay, visual feedback indicated the actual outcome of the trial. The participants were told that responding rapidly would maximize their chances of obtaining gains and avoiding penalties. However, gains and penalties were actually delivered in a predetermined pattern. Half of the trials in which the cue indicated a reward yielded monetary gains, and half ended with no change in value. Likewise, half the trials in which the cue indicated a loss yielded a monetary penalty, and half resulted in no change. When the cue provided no incentive, the outcome was always no change. To maximize believability, the target duration was longer for trials that were scheduled to be successful than for those scheduled to be unsuccessful. After 2 sets of trials, the participants rated their affective responses to the cues and outcomes, in terms of both valence and intensity. The difference in reaction time between the incentive and no incentive trials was smaller for the patients with major depression. In addition, they reported generally less positive affect in response to the reward cues and less intense responses following gains. Surprisingly, the brain imaging showed robust basal ganglia responses to the reward cues in both groups. However, the depressed group showed weaker activation in the left posterior putamen. To judge the response to reward outcomes, the reactions to gains in monetary value were compared with the reactions to the feedback indicating no change. This difference was less for the depressed patients than the comparison subjects in the left nucleus accumbens and the dorsal caudate bilaterally, including 2 subregions in the right caudate and 2 in the left caudate. Moreover, whereas the comparison subjects showed increased caudate activation bilaterally in response to both gains and losses, relative to no change, the depressed participants didn't show any feedback-dependent caudate modulation. Secondary analyses examined relationships between basal ganglia volumes and symptoms among the depressed patients. The volumes of both the left and right caudate were inversely related to the total score on the Beck Depression Inventory and to the subscore for anhedonia. These findings suggest that basal ganglia dysfunction in major depression is more closely related to consummatory deficits, rather than anticipatory deficits, in reward processing, and they emphasize a role for reduced caudate volume in anhedonia. Inhibitory control in attention deficit hyperactivity disorder was the focus of Lisa Gose and colleagues. They validated and extended the endophenotype model in ADHD by studying patterns of inheritance in a family study of inhibitory control. ADHD is highly heritable, but genetic studies have been frustrated by heterogeneity among the probands. Therefore, consideration has turned to endophenotypes, traits of the disorder that are thought to be less genetically complex than the broader disease phenotype. Deficient inhibition of motor responses meets many of their criteria for an endophenotype for ADHD. It's been demonstrated in siblings of probands with ADHD, and the current study focused on parents. Their genetic relationship to probands differs from that of siblings, and might be subject to sex-based regulatory phenomena, such as genomic imprinting. This refers to variation in the expression of a gene in the offspring according to which parent contributed the gene. The participants in the study were from 75 families referred to a child psychiatry clinic. Each family included at least one affected child, for a total of 113 children with ADHD. Healthy comparison children and adults were also recruited. The majority of the children with ADHD were attending their initial appointment and were not taking medication. For the others, the minimum withdrawal period before testing was 48 hours. All participants completed the stop signal task, which assesses the ability to inhibit an ongoing action. A longer reaction time reflects less inhibitory control. In the children, the stop signal reaction time was significantly predicted by age and by parental reaction time, but not by sex, number of symptoms, or number of symptoms in the parent. To determine whether the influence of age or parental reaction time differed in the affected and unaffected children, the analysis was repeated with these interactions specified. The interaction of diagnosis and parental reaction time was not a significant predictor of the child's reaction time. Thus, the covariance of parental and child reaction times occurred across the full measure of inhibitory control, not just within the impaired range. Further analysis revealed that the child's stop signal reaction time was significantly predicted by the reaction time of the father, but not the mother. However, the influence of parental reaction time on the child's reaction time did not vary by the child's sex. The parents of children with ADHD had inhibitory control that was poorer than the comparison adults. Parental reaction time was not significantly predicted by age, sex, or number of symptoms. Likewise, the affected children had significantly longer reaction times than the comparison children. Unaffected siblings had times intermediate to those of the affected children and comparison children, but they didn't differ from either group. Our final article is a report on drug treatment of acute schizophrenia episodes. Carla Canuso and colleagues conducted a randomized, double-blind, placebo-controlled study of extended-release paliperidone and quetiapine in patients with recently exacerbated schizophrenia. Extended-release paliperidone is an atypical antipsychotic with a rapid onset of efficacy in clinical studies. It's released osmotically and minimizes peak-to-trough fluctuation, and it can be initiated at a therapeutic dose. In contrast to other antipsychotics, it undergoes limited hepatic metabolism, and it has a low likelihood of hepatically mediated drug-drug interactions in patients receiving polypharmacy. It was compared with placebo and quetiapine, which is the most widely prescribed atypical antipsychotic. The trial included 2 phases. The first was 2 weeks of monotherapy, followed by 4 weeks of more naturalistic treatment, to explore the effects of polypharmacy. Nearly 400 patients with acute exacerbations of schizophrenia were randomly assigned to extended-release paliperidone, quetiapine, or placebo. Paliperidone was initiated at 6 mg per day and was increased to 9 mg at day 4, with an optional increase to 12 mg at day 8. Quetiapine was initiated at 50 mg per day, and the dose was increased gradually to 600 mg on day 5, with an optional increase to 800 mg on day 8. During the second study phase, patients continued on the dose received at the end of the first 2 weeks. Other psychotropic medications were prohibited during monotherapy, except for injectable medications as needed for severe agitation or restlessness, and treatments for insomnia and movement disorders. During the second study phase, other psychotropic medications, including antipsychotics, were permitted. Efficacy was assessed with the Positive and Negative Syndrome Scale, or PANSS, and the Severity and Change Ratings from the Clinical Global Impressions, or CGI, scale, with the last observations carried forward. Improvement in PANSS total score during monotherapy was greater with paliperidone than quetiapine. Paliperidone showed greater improvement than placebo beginning on day 5, whereas quetiapine separated from placebo only at day 9. Changes on 4 of 5 PANSS factors were also greater with paliperidone than quetiapine or placebo. Quetiapine was similar to placebo. On the CGI severity and change ratings, paliperidone was better than both quetiapine and placebo at the end of monotherapy, whereas quetiapine did not separate from placebo during the initial 2 weeks. A composite measure of response was also applied. It combined a reduction of 30% or more in the total score on the PANSS, plus a rating of 1 or 2 on the CGI change scale. According to this criterion, 40% of the patients treated with paliperidone responded to treatment, compared with 31% of the quetiapine group, but these proportions were not significantly different. Just over half of the patients receiving paliperidone and those taking quetiapine received additional psychotropic medications during the second phase of treatment. Although the differences in efficacy between paliperidone and quetiapine persisted, they appeared to be largely due to the changes during monotherapy. Over the entire study period, Serious adverse events were reported for 8% of the patients in the paliperidone group, 4% in the quetiapine group, and 3% in the placebo group. Paliperidone was associated with more reports of hypertonia, tremor, and hyperprolactinemia, whereas quetiapine was associated with higher rates of dizziness, sedation, and somnolence, and a greater effect on thyroid hormone levels. This concludes the audio highlights of the June issue of the American Journal of Psychiatry. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including author affiliations and disclosure of competing interests. We also welcome comments regarding this audio. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, AJP Deputy Editor Susan Schultz returns to discuss the mental health benefits of foster care in Romania, depression in bereaved youth 21 months after a parent's death, the course of bipolar disorder in children and adolescents, auditory training to improve verbal memory in schizophrenia, and differential expression of metabotropic glutamate receptor 2 and 3 in schizophrenia. We hope you'll join us again. Thank you.